Well, I'm curious to know, for the patients that you have sitting in front of you who you're considering giving T-DXd in the adjuvant setting, what are you talking to those patients about in terms of supportive care, what symptoms they may experience, and how to try to mitigate some of those symptoms? We know cold capping doesn't always work so well in antibody drug conjugates, but these patients may experience hair loss, they may experience nausea, they may experience fatigue. So what are these conversations looking like?
These are tough conversations because if a patient has gone through preoperative therapy with, for example, TCHP, which we're giving quite a bit in the neoadjuvant setting, there is treatment fatigue, right, on the other side of it. They've gone through a lot of therapy preoperatively. They've gone through surgery, healing from surgery, and then sitting with them and seeing the pathology report. I often try to frame it as this isn't a failure of systemic therapy, but the surgery gave us really important information about the biology of your disease.
Absolutely.
And this allows us to offer you a really effective, tailored treatment and engage with the patient such that they understand the importance of this additional therapy, make them part of the treatment team.
Yeah.
Because they have to understand the benefit of the therapy, and understanding that in the adjuvant setting, about 72% of patients were able to complete that year of, or the 14 cycles of T-DXd. A lot of that has to do with our ability to offer them support through some of the toxicities. So of course, we talk to our patients a lot about the risk of ILD and how they will be monitored, understanding also that there are other toxicities that are also very important to patients, nausea, and making sure we're giving antiemetic, triple drug antiemetic prophylaxis. I don't think we do as great of a job talking about fatigue, because this drug can cause significant fatigue. And I think we have to be very pointed in bringing this up as a potential side effect and assessing fatigue at each office visit, offering patients dose reductions if needed, ruling out other causes of fatigue, making sure that there isn't an issue, cardiopulmonary issue. Remember, these drugs, or this drug, can cause an issue with a drop in ejection fraction, although not often, but still needs to be monitored. There were patients that had those issues. So that can present as fatigue, not becoming tunnel focused and thinking that there's maybe something else going on, like thyroid issue, anemia, nutritional deficiencies. So I think our ability to get patients through these 14 cycles is very much linked to our attention to their side effects and being proactive.
Absolutely.
Yeah, and you mentioned anemia. Anemia is something that we see not too infrequently when we operate on this patient. We operate hemoglobin on 8 and 9, not uncommonly.
Right.
They do fine, but then again, that's something that you have to think about when you start the next regimen afterwards.
And fatigue is so tricky. It's really hard to try to get good quality information about fatigue. Really, fatigue may look so different to, everybody. You may have a patient who's saying, I'm fatigued, and you're like, well, I'm fatigued too. But that fatigue is very different. That is a patient who's not able to leave their home. They're not able to get out of bed. They're not able to function the way they do. And that is a fatigue that certainly warrants, as you said, Dr. Mahtani and Dr. Mamounas, certain attention to other factors that may be playing a role, and then acting appropriately on T-DXd, dose adjustments and things like that.